Assalamu alaikum. Our lecture today is about steroid in neonatology, part 2. This is lecture presented by me, Dr. Ammar Al-Rahal, pediatrician and NICU fellow. This lecture is supervised by Dr. Muhannad Muallim, NICU consultant. The objectives of this lecture are to review the current evidence and guidelines on steroid use in neonatology. The lecture will focus on 4 main points: the benefits of antenatal steroids for preterm babies, the benefits and the risks of early postnatal corticosteroids. We'll refer here to this PNC. The role of late postnatal corticosteroid for preterm infants. Finally, we will talk about the general recommendation or suggest recommendation for postnatal corticosteroids. At the first, antenatal corticosteroids help the lungs of premature babies to develop faster. ACS have many benefits for preterm babies. We talk about it last lecture, such as reducing the risk of mortality, IPH, and bronchopulmonary dysplasia, and necrotizing enterocolitis. They also improve renal function and skin maturation. ACS have maximum efficacy when given at 2 to 7 days before delivery. Approved ACS to use are dexamethasone and betamethasone, but not hydrocortisone, because hydrocortisone is extensively metabolized by placental enzymes. However, there is some controversy about when to use ACS. Most guidelines recommended giving ACS to pregnant women who are at risk of preterm delivery between 23 and 34 weeks gestation. After 34 weeks, the recommendation is vary. ACOG and RCOG suggest using ACS up to 36.6 weeks, while European guideline doesn't. Some possible harm of ACS include increased risk of small for gestational age, hypoglycemia, and mental or behavioral disorders. And this harm, we talk about it last lecture, increased by repeated ACS courses. We just for remember, early postnatal corticosteroid mean within 7 days of birth, and late postnatal corticosteroid mean after 7 days of birth in this lecture. Here we will talk about largest study in about early postnatal corticosteroids. This is a systematic review conducted by Doyle et al. Included a sample of more than 4,000 preterm infants across 32 trials. The review aimed to assess the overall impact of 2 interventions, dexamethasone and hydrocortisone, for preterm infant at risk of developing bronchopulmonary dysplasia. 21 trials of dexamethasone and 11 trials of hydrocortisone included in the analysis. Results of this review were earlier extubation, decreased risk for bronchopulmonary dysplasia, and PDA, and severe retinopathy of prematurity, ROP. But these benefits offset by short harm, GI perforation, and long-term harm, increased risk for cerebral palsy. Most benefits and harm are attributed to dexamethasone. Risk of GI perforation attributed to hydrocortisone. Overall, in early postnatal corticosteroid, the potential benefits of dexamethasone in the first weeks post-birth are offset by substantial side effects. Dexamethasone is therefore not recommended for prevention of bronchopulmonary dysplasia. And in last lecture, we discussed some studies about physiological hydrocortisone, and based on current evidence, physiological hydrocortisone at replacement doses initiated in the first 24 to 48 hours post-birth in infant born less than 28 weeks gestational age, when not associated with prophylactic indomethacin, increases survival without bronchopulmonary dysplasia at 36 weeks, and survival before discharge without harmful effects on neurodevelopmental at 2 years. But maybe it's evidence-based, but maybe it's not routinely recommended. Now about early inhaled corticosteroids. Based on current evidence, any beneficial effects of on bronchopulmonary dysplasia rates appear to be offset by increased risk of mortality. Administration inhaled corticosteroids such as budesonide and fluticasone, therefore, the first 2 weeks post-birth to prevent bronchopulmonary dysplasia is not recommended routinely. Now we talk about late postnatal corticosteroids, mean after 7 days. No new trial of late dexamethasone treatment has been published since 2012. One single center pilot randomized control trial and one multi-center randomized control trial investigate hydrocortisone succinate were reported since then. In 2018, a randomized control trial reported no difference in the combined outcome of death or bronchopulmonary dysplasia at 36 weeks, corrected gestational age, but found decrease in death in infant who received hydrocortisone. This study conducted by Barek et al. This randomized control trials included preterm infant less or equal to 1,000 grams at birth, ventilator dependent at 10 to 21 days of age. In this study, intervention was hydrocortisone succinate for 7 days, 3 milligram per kilogram for in day 1, and to 1 milligram per kilogram for day 7. Main result of this study were about brain volume at 38 weeks of age, and this the results was no difference, and no difference in bronchopulmonary dysplasia or duration of mechanical ventilation. This another study and large study, randomized control trial conducted by Holland et al. Included the preterm infant less than 13 weeks at birth and ventilated at 7 to 14 days. Intervention was hydrocortisone, winning over 22 days. Cumulative dose was 72 milligram per kilogram. The main result were death or bronchopulmonary dysplasia at 36 weeks, 70% versus 74. Mortality was 16 versus 24. In this study conducted by Dial et al., this Cochrane systematic review concluded by Dial et al. Included the preterm infant with evolving or established bronchopulmonary dysplasia, dexamethasone or hydrocortisone given IV or Beros for 7 to 42 days. Total dose varied across trials. The main result were facilitated extubation on study day 3 and 7 and 28 day, less bronchopulmonary dysplasia and less discharge on home oxygen, increased risk of severe ROP, but no increase in blindness. There was no difference in death rates at 36 weeks, and no difference in cerebral palsy. In the summary, the routine use of dexamethasone for all infants who required assisted ventilation after 7 days of age to treat evolving bronchopulmonary dysplasia is not recommended, nor can hydrocortisone to treat evolving bronchopulmonary dysplasia be recommended at this time. The result of ongoing trials are awaited. About inhaled corticosteroids after the first week, one updated Cochrane systematic review in 2017 included 8 trials. Some infants were ventilated while others were not. The treatment was initiated between 7 and 21 days post-birth. A meta-analysis should reduce the risk for failure to extubation at 7 days in infants who received inhaled corticosteroids. No difference was noted in the rate of death of bronchopulmonary dysplasia. The conclusions are limited in this study because a small number of infants enrolled and the heterogeneity of patient and inhalation therapy. At the end, this is home message. Early low dose hydrocortisone, not routinely recommended. It's now object of multiple study, but may be considered in some cases. Early dexamethasone, not recommended. Early inhaled corticosteroid also not recommended. Late low dose hydrocortisone also not routinely recommended, but may be considered in some cases. And late dexamethasone also may be considered in some cases. Maybe not to prevent bronchopulmonary dysplasia, but for facilitate extubation. And late inhaled corticosteroid not recommended. Thank you.
الله يعطيك العافية عمار. I have to ask a few questions لأنه I need to go soon. So those recommendations that you put, is it based on the thematic analysis that you presented or based on your review of the literature? Where did those recommendations come from?
دكتور بس عفوا الصوت أنا ما بعرف كأنه عندي مشكلة بالصوت، ما سمعت السؤال تقريبا أبدا.
السؤال انه هدول التوصيات اللي حطيتها باخر المحاضره هي نعم. توصيات من السيستماتيك ريفيو ولا توصيات انت يعني بنيتها اعتمادا على الريفيو اللي سويته؟ شو مصدر التوصيات؟ السؤال.
نعم دكتور، هاي التوصيات مذكوره المقالات المذكوره ب كنديان بيدياتريكس موجوده، ولكن حقيقه انا عدلت عليها شيء بسيط اعتمادا على الدراسات اللي ذكرتها في المحاضره. مثلا ليت ديكساميثازون كاتبين may be considered، كان مكتوب not routinely recommended but may be considered in some cases او ما شابه، بس انا اختصرتها انه may be considered، بس هي تقريبا نفس المعنى يعني.
تمام. عملت ريفيو للريسنت AAP recommendation about postnatal steroid use؟
نعم دكتور، انا شفت كثير يعني بصراحه شفت كثير دراسات، في كثير من الدراسات متضارب يعني بالنسبه لل use or not to use يعني، وغالبا for bronchopulmonary dysplasia it's not recommended but may be recommended for another personal reasons.
تمام. انا اللي عم بحكي ال AAP last year they came up with a statement about postnatal steroid use that includes that did a systematic review of the dexamethasone studies and the hydrocortisone studies, and based on that they came up with some professional recommendations. It's only recommendations, it's not like, you know, guidelines per se. It's not enforcing is what I'm trying to say. And at least the consideration right now, maybe it's not clearly mentioned in the guidelines or in the professional statement. People are now considering calculating the risk of PPD based on a risk calculation depending on the amount of oxygen and respiratory support that they are on. And if their risk is really high, then a consideration of late hydrocortisone, or more strongly, the dexamethasone is at least the current opinion about the steroid use. Yes, routine use is definitely not recommended. It's mainly based on PPD risk analysis, based on case-to-case and the amount of the respiratory support that each baby is on. So at least that's the common practice mainly used in the United States. Now, there is still more studies that need to be done about late hydrocortisone use because it's only limited neurodevelopmental outcome data is available to this point about the steroids, about the hydrocortisone specific use. But the dexamethasone is more commonly used in most centers, or at least there is a split between the dexamethasone use and the hydrocortisone use, with some hope that the hydrocortisone might not have a neurodevelopmental impact like the dex does. So that's kind of quick summary about at least the common practice that we have in the United States. Thank you.
Thank you, Doctor. This is maybe a newest recommendation. I didn't see it. Maybe in general يعني تشابه إلى حد بعيد التوصيات المذكورة هنا، ولكن ربما في يعني تحديد أكثر. النقطة إنه الليت ديكساميثازون مذكور في بروتوكول دارت، لذلك هو ربما شائع جدا. يعني maybe late hydrocortisone more benefits or more or less complications. ما شفت أنا بصراحة ما شفت يعني شيء واضح بهذا الموضوع. أي
صوت متقطع عمار.
والله دكتور ما بعرف شو المشكلة عندي، حتى باللابتوب ما قدرت أحيانا بحكي من الموبايل.
هيك أوضح.
بس عم بقول إنه في ملاحظات أو شيء على المحاضرة. محاضرة خفيفة اليوم الحمد لله، يعني بسيطة.
يعطيكم العافية، ممتاز جدا. يعني الصراحة السلايدز كانت ممتازة، برزنتيشن ممتازة، ديسكشن الله يجزاكم خير أنت والدكتور محمد. طبعا نحن في نقطة هامة جدا بالنسبة ل طب حديثي الولادة بالعموم. صحيح نحن لساتنا عم نشتغل في منطقة لسه تطوير طب حديثي الولادة في التيرم بيبيز ونير تيرم بيبيز والليت بري تيرم. أعتقد قدامنا مشوار طويل جدا جدا لنحكي عن موضوع very low birth weight والextremely low birth weight. يعني وقت عم تحكي أنت مثلا بالكومبليكيشن والأشياء اللي بتشكل صراحة هي معظم التوبكس في النيوناتولوجي، مثل التوبك تبع اليوم، هي كلياتها في الأوزان المنخفضة جدا. يعني إحنا لساتنا في منطقة السبسز اللي هو منتشر سكاي هاي. برأيي التركيز عليه هو أهم شيء حاليا. يعني مع الوقت إن شاء الله تعالى نوصل، لأنه يصير في عندنا سرفايفل للأوزان القليلة جدا، اللي ممكن نقول والله هذه المواضيع اللي عم نناقشها ما عم نناقشها لأمور نظرية، وإنما عم نناقشها لواقع عملي. إن شاء الله تعالى يعني بتكون على إيديكم في المستقبل. يعطيكم العافية، الله يجزاكم الخير.